Hi guys, good evening. Let's continue. So this session of our foray is dedicated for hepatobiliary. So we'll be talking about important topics of hepatobiliary. Hi Padma, good evening. ठीक है, चलो. So in the hepatobiliary, what do we? So what do we have in the hepatobiliary? So your previous exam questions are pyogenic liver abscess and its management, pyogenic liver abscess, amoebic liver abscess, pyogenic liver abscess, amoebic liver abscess, and the hydrated cyst of the hydrated cyst of liver. They're going to be the hydrated cyst of the liver, right? Then there was a question between, again, there's a question to differentiate between pyogenic and amoebic liver abscess. So there's a combination that they've asked you previously also, right? All these are short questions which are going to be there. Then they ask you about cholecystitis, cholecystitis, choledocholithiasis, cholecystitis, choledocholithiasis, right? Then they ask you about Courvoisier's law. Right. So these are the questions which are asked. Is there any schedule for the lecture, sir? Walid, we have a schedule. We have already posted. No, we have posted all the important topics which are going to be covered in Farre series, and that is going to be in a progression. We missed a couple of lectures, so we have covered that one today. Hepatobiliary is one of them. Another one is GIT part 2. We have missed it. That is going to be scheduled next week. Okay. Otherwise, all the topics are being covered in a systematic manner. You can just go watch it once, right? So we'll be talking about, so what happened, no, majority of the questions that come from the hepatobiliaries are usually 5-mark questions. If a combination of two questions are given, they're made it to a 10 marks question, but this is more or less relevant from this point of view. So we'll talk about the liver abscesses first. So what we have is, in all the infectious disorders of the liver, so I'll talk about all the infectious disorders of the liver. Or I say liver infections. Now, when you talk about the liver infections, to impress your examiner, we'll do a comparative data. So we'll be talking about pyogenic liver abscess, your pyogenic liver abscess, amoebic liver abscess, pyogenic liver abscess, amoebic liver abscess, and the hydrated cyst, and the hydrated cyst of the liver. Right, so what we'll do is we'll do a comparative table so that we'll remember every single context, so that it's easier for us to construct it back. Right, so when you talk about the three disorders that we're going to talk about, one is going to be pyogenic liver abscess, amoebic liver abscess, and the hydrated cyst. Sabse pehle, what is the causative agent? Causative agent for all three of them, right? Pyogenic liver abscess is caused by bacteria. The other two disorders are caused by a parasite. right? So pyogenic liver abscess is caused by bacteria, amoebic liver abscess is caused by parasite, right? When you look at the most common organisms, so the organisms responsible here, it is usually caused by E. coli and Klebsiella. It is usually caused by Klebsiella. Whereas amoebic liver abscess, it is caused by Entamoeba histolytica, and hydrated cyst is caused by Echinococcus granulosus. It is caused by Echinococcus granulosus. That's a causative agent, right? Now, how does they reach to the liver? So, what is the route of spread? What is the route of spread? Now, when you talk about the route of spread of pyogenic liver abscess, it can travel into the liver via the bile duct. It can travel into the liver via the portal vein. It can also travel into the liver with the help of the hepatic artery. It's the hepatic artery or the direct route of spread. So what happens is in the bile duct, now when it is going to travel via the bile duct, the basic concept is until unless there is no obstruction to the bile flow, these organisms cannot ascend into the liver. But if there's an obstruction to the bile flow, like example of CVD obstruction or any obstructive jaundice, you can see these organisms are going to take an ascending route, goes into the liver and start causing the problem there. Okay. Via the portal vein, many GI infections, especially appendicular abscess, appendix and all that. No, from there the organism can go into portal vein, from portal vein into liver. Hepatic artery, again, if there is systemic sepsis there, it can result in pyogenic liver abscess. Direct route, it can be secondary to the nearby organs. For example, there is an infection in the gallbladder. For example, you have the empyema gallbladder or the you have nephritis, which is on the kidneys per se. So all these can cause, or you can have the right-sided pyothorax, right? All these can result in direct route of infection into the liver. Okay. When it comes down to amoebic liver abscess, the story is quite interesting because the route of infestation, right? So what is the route by which it gets into the body? It is your feco-oral route of contamination. Now when it becomes the feco-oral route of contamination, it goes into the cecum, and in the cecum it is going to result in flask-shaped ulcers. It will result in development of flask-shaped ulcers. Now these flask-shaped ulcers will result in a condition called as amoebic colitis. It will result in amoebic colitis. Now from the amoebic colitis, it is now going to go into the portal circulation. Via the portal vein, it is now going to reach down to the liver. So the Entamoeba histolytica, is going to reach to the liver with the help of the portal circulation. Now, if you observe very carefully, even when it reaches to the liver, even when it is reaching to the liver, when it reaches the liver, what is the infective stage that you have? In the flask-shaped ulcers, no, they result, say, amoebic colitis goes into portal vein. What goes in the portal vein? It is the infective stage of the Entamoeba histolytica, and that is nothing but tetranucleate cyst. It is the tetranucleate cyst which is going to get into the liver. This is a tetranucleate cyst that is going to go into the liver, and from there it is going to result in amoebic liver abscess. Whereas Echinococcus granulosus, it occurs, so you need to understand that it is an example of zoonosis. So when I say zoonosis, this is an infection which usually spreads from animal to animal. Humans are accidental host. Humans are actually accidental host, right? And remember, human to human transmission does not occur. Human to human transmission does not occur. Now this occurs because of improper cooked meat. It occurs because of improper cooked meat infested with Echinococcus granulosus. It occurs because of improperly cooked meat infested with Echinococcus granulosus, right? So this is with respect to your hydrated cyst. Now, one common thing that they might expect you from the hydrated cyst is what is a definitive host and who is going to be an intermediate host. Remember three things. One is your definitive host, where there is a sexual cycle. Then there is an intermediate host through which it is going to transmit. And the last one we have is the accidental host, right? So when you talk about the definitive host is going to be dog. The intermediate is going to be sheep. And the accidental hosts are going to be humans. So dog, sheep and humans are the three hosts that you need to remember: definitive, intermediate and the accidental host. Right? This is how the organism is going to reach inside the liver. Now, when it reaches down to the liver, we should now understand that what are the any attributed factors are there. They are called risk factors. Now, the risk factors associated with pyogenic liver abscess, it is alcohol and diabetes. Here it is only alcohol. In hydrated cyst, there is no specific risk factor. Then they ask you in terms of clinical presentation, what is the usual age of presentation? Remember, the usual age of presentation here is going to be 40 to 50 years. Amoebic liver abscess 20 to 30 years. Usually hydrated cyst is seen in the same age group, that is 30 to 40 years. Or else we can just say this is usually seen in age above 50 years and hydrated cyst is usually seen in age above 40 years. Is usually seen in age above 40 years. So who are more likely to be affected? Now alcohol is a risk factor, so needless to tell you, wherever alcohol becomes a risk factor, males are more likely to be affected when compared to females. And here males and females will be equally affected. That is going to be in the context of your hydrated cyst. As simple as that. Okay. Now let's understand how would they land up. How would they land up with the clinical presentation? So we'll talk about the clinical features. We'll talk about the clinical features. Now, when we talk about the pyogenic liver abscess or amoebic liver abscess, any inflammation of the liver will respond as any inflammation in the body. And everywhere there is inflammation in the body, it has a rubor, calor, dollar, tumor, same thing is going to happen. So here, as there is the bacteria gets into the liver, it will start to proliferate, hence causing inflammation, and that inflammatory response will cause rubor, calor, dollar tumors. So first there will be presence of, now what happens, inflammation will cause edema. Edema will cause swelling of the liver. When the liver expands or enlarges, it stretches your Gleason's capsule, which is pain sensitive. When the Gleason's capsule is stretched, that is where the patient complains of pain. So patient will have right hypochondriac pain. There is presence of this right hypochondriac pain is present. Now, along with right hypochondrium or the hypochondriac pain, patient will also be associated with high-grade fever. Right? So there is right hypochondriac pain. It is associated with high-grade fever. Every disorder of liver is going to be associated with anorexia, as well as fatigue. There will be anorexia as well as fatigue. Now, when you take a history or when you try to examine, you will notice, right? Obviously, there's a bit of enlarged liver, but that's not very expansive or very evident on a clinical examination. So, right hypochondriac pain is there, high-grade fever, anorexia, and then you examine, there is right hypochondriac tenderness is also noticed. This tenderness is also noticed. Along with that, you will notice that these patients, who have pyogenic liver abscess, because usually it ascends via the bile duct, and I just told you there has to be some history of CVD obstruction, so they can also be presented with obstructive jaundice. They can also be associated with obstructive jaundice, but obstructive jaundice is usually seen only in 20% of the patients. It is seen only in the 20% of the patient, right? Amoebic liver abscess, on the other hand, it is also an inflammation. So here there will be present right hypochondriac pain. It will also have high grade fever. It will also have anorexia, fatigue. It will also have tenderness. It will not have jaundice. It will have history of colitis. There will be history of colitis. So patient said that he was admitted because of diarrhea. Patient had severe abdominal pain. There's some amount of hematochezia was also present, or I can say melena was present. Then the patient was started on medication, usually on metronidazole. Patient responded, and when they come back with that response, they're usually associated with your amoebic liver abscess. Yeah? Now, hydrated cyst, remember, usually it is asymptomatic. Hydrated cyst is usually asymptomatic. So incidentally found enlarged liver. This is usually incidentally found enlarged liver span. Then incidentally found enlarged liver. As simple as that's the only presentation that you have hydrated cyst. Now those who are symptomatic in hydrated cyst, symptomatic hydrated cyst will have palpable liver mass, or I can say there's presence of palpable liver. There is this palpable liver is present. So there's an incidentally found enlarged liver. There is presence of this palpable liver that you are able to see. Along with that, because it compresses onto the esophagus as well, it will be associated with dyspepsia as well as dysphagia. It will be associated with dyspepsia as well as dysphagia. This will be associated with dyspepsia as well as dysphagia. So this is how the clinical presentation of each individual component is going to be present. Now I would like to evaluate in terms of investigation. Let's see. Right. So let's talk about investigations. Now in terms of investigation, remember, whenever there is pain abdomen, the first investigation would be of ultrasound. So ultrasound will quantify that there is presence of liver infection. Now along with ultrasound, you can also do a CECT of the abdomen. Now in order to confirm, you can also do culture. For amoebic liver abscess, you can perform an ultrasound. Go ahead with CECT abdomen. Remember, parasites cannot be cultured. Now because they cannot be cultured, but you can do ELISA. Same for hydrated cyst. You can go with ultrasound, perform a CECT. Perform a CECT abdomen, and then take the patient for ELISA as well. Earlier, hydrated cyst has a test called as Cassini's test. Now it is obsolete. We don't follow it any longer. Right. Now, based upon the investigation, if I say what is the usual site, right? So the most common site for all these disorders, this is usually seen on right hemi liver. This is also on the right side of the liver. So this is also seen on the right hemi liver. And this is also seen on the right hemi liver. They're also seen on the right hemi liver. So all these disorders are more common on the right side of the liver. They're more common on the right side of the liver, right? Because one more thing that you should not miss in all these liver disorders is to do a liver function test. So you will do an LFT, that is liver function test. So in pyogenic liver abscess, that is PLA, in pyogenic liver abscess, alkaline phosphatase will be elevated. So ALP is elevated in pyogenic liver abscess. It's one of the most reliable, I would say the most common LFT abnormality that you will see in a pyogenic liver abscess. As simple as that, right? Now once you have gotten, how would you like to manage? Now for pyogenic liver abscess, I'm going to go ahead with USG guided. I'm going to do a USG guided drainage with antibiotics. That's the first line. So as a first line management, you go USG guided aspiration with antibiotics. If it does not work, the second is going to be USG guided pigtail insertion. USG guided pigtail insertion with antibiotics. If this does not occur, then it is going to be open liver drainage. With antibiotics. So you have a USG guided drainage with antibiotics, USG guided pigtail insertion with antibiotics, and then open drainage if it does not work out. For amoebic liver abscess, before we start the management, remember amoebic liver abscess. Amoebic liver abscess is not a true abscess. It is not a true abscess. It's a presentation. It's a presentation, or I can say it's not true abscess. It is liquefactive necrosis. It is liquefactive necrosis. So amoebic liver abscess is not a true abscess. It's actually an example of a liquefactive necrosis. It is usually an example of a liquefactive necrosis. Now, because it's an example of liquefactive necrosis, the first line management that you will do is going to be a high dose metronidazole. It's a high dose metronidazole. So when I say high dose metronidazole, it is going to be 700 to 1000 milligrams. That is going to be 3 times a day for 14 days. So this is what we follow. This is what we follow for your amoebic liver abscess. If there is no response to metronidazole, if there is no response to metronidazole, then you have to go with USG guided aspiration with antibiotics. Then you have to go with USG guided aspiration with antibiotics. It is a USG guided aspiration with antibiotics. So when you have a USG guided aspiration with antibiotics, one of the most characteristic feature that you will see is presence of an anchovy sauce appearance. Now this anchovy sauce is like a chocolate brown sauce. This is a chocolate brown colored sauce. So this is with respect to amoebic liver abscess. For hydrated cyst, we do something called as the pair therapy. So the first line is going to be pair, that is percutaneous aspiration. It's percutaneous aspiration, instillation of scolicide lesion, instillation of scolicide lesion, and re-aspiration. So percutaneous aspiration, instillation of scolicide lesion, and re-aspiration. Now we talk about what are the scolicidal agents that we have. The scolicidal agents that we have is going to be 10% povidone, 0.5% centrimide, 0.05% chlorhexidine, 0.05% chlorhexidine, hypertonic saline. That is your pair therapy. That's a pair therapy, right? Now, along with pair, you have to do capitonage as well. Capitonage is basically to obliterate the cavity. You'll suture to close it. This is to obliterate. Obliterate the cavity. So this is how you'll manage your hydrated cyst as well, right? So we covered all three questions. There are two questions where they asked on comparative basis and the other ones like each individual one. So you know what to write it when you get it from start to end. So we have covered the first three questions. Pyogenic liver abscess, amoebic liver abscess, and the hydrated cyst of the liver. One more question that they asked you is Child-Pugh classification. Now when we talk about the Child-Pugh classification, it's also called a CPC. I'll just quickly run here in liver only. So let's talk about the CPC's classification, also called as the Child-Pugh classification. So when we talk about the Child-Pugh classification, child is basically in Hindi it means बच्चा, ठीक है? तो बच्चे का बाप होता है. तो Child-Pugh classification जो factors हैं, they can be remembered by small mnemonic which is called as BAP. Now this BAP is very energetic, so remember it's BAPI. Now the components on which we are going to measure is going to be in this context, and you'll give a score of 1, a score of 2, and a score of 3 is given. Now what does all this means? B stands for the level of bilirubin. All this bilirubin will be measured in milligrams per deciliter. Then A stands for albumin. Albumin is grams per deciliter. A stands for ascites, which is going to be quantifiable. P stands for increase in prothrombin time. Increase in prothrombin time. And E stands for status of encephalopathy. So you have the bilirubin, albumin, ascites, increase in prothrombin time, and encephalitis, right? So when you look at the level of bilirubin, if it is less than 2, a score of 1. If it is between 2 to 3, a score of 2. More than 3, a score of 3 is there. Albumin more than 3.5 is a score of 1. If it is between 2.8 to 3.5, a score of 2. Less than 2.8, a score of 3 is given. Ascites absent is a score of 0. Slight is going to be score of 2. Moderate ascites is going to be a score of 3. Increase in prothrombin time, if it is between 1 to 3 seconds, score of 1. 4 to 6 seconds, score of 2. More than 6 seconds, a score of 3. Encephalopathy absent is okay, 0 means score of 1. Then it is minimal, score of 2. And then if it is advanced, a score of 3 is given, right? So these are the factors by which you are going to classify your Child-Pugh's classification. Remember the mnemonic and all these components. I know थोड़ा difficult है values याद रखने के लिए, लेकिन medicine किसने बोला था कि आसान है, ठीक है? तो थोड़ी बहुत difficult चीजें भी करनी पड़ेंगी, ठीक है? So this is your Child-Pugh classification. Now based upon the total score, we can classify. Just give me a second. I've got a little bit obsession with lines, ठीक है? तो line मारना important है और सीधी मारना important है, ठीक है? आड़ी तिरछी नहीं मारना. Okay, so when you calculate the total score के basis पे we have 3 classes. We have Child-Pugh CP class A. We have Child-Pugh class A. Then you have CP class B. And you have CP class C. Now it's a class A. If the total score is less than or equal to 6. If it is 7 to 9, it is class B. If it is more than or equal to 10, it is class C. More the score, higher the class, poorer is the prognosis, ठीक है? तो जितना ज़्यादा स्कोर होगा उतना बड़ा क्लास मिलेगा, और जितना बड़ा क्लास मिलेगा उतना पुअर प्रोग्नोसिस होगा, ठीक है? दिस इज विद अवर Child-Pugh क्लासिफिकेशन, ठीक है? तो ये भी हमने अभी निपटा लिया. So Child-Pugh classification is also sorted. Now we'll be talking about cholecystitis, choledocholithiasis, and the Courvoisier's law. Okay, ये तीन factors हैं that we have to go accordingly. Let's talk about choledocholithiasis. Choledocholithiasis is also referred to as gallstones. Also referred to as the gallstones. Okay. So we'll try to understand all the points and what was asked in the exam. That is going to be about gallstones. Now, when we talk about choledocholithiasis, as we said in nephrolithiasis, we'll start the same statement. 90% of gallstones are radiolucent. They are radiolucent, and 10% of the gallstones 10% of the gallstones are radio opaque. They are radio opaque. Right. Now, based upon the composition, when I say the types of the gallbladder, so we'll have three different varieties of the gallstones. So we'll talk about the gallstones in general. We have the calcium oxalate stones, pigmented stones, and the mixed variety. Right, so we have the cholesterol stone, we have the pigmented stone, and then we have a mixed variety. So when I say mixed, it's a combination of both cholesterol as well as pigments. It's a combination of both cholesterol as well as pigments. So we'll try to understand that what results in development of a cholesterol stones. So what are the causes? We're trying to determine the cause for each one of them. Now the cause for development of the cholesterol stone, number one, there has to be obviously one, you need to have supersaturation of the bile, then you need to have stasis of the bile, and also the nucleating factors. Now examples that will fit into this is going to be obesity, high fat intake, obesity is there, high fat intake, secondary to an ileal resection. Hold on for a second, guys. I'm just going to call from hospital. Alright, guys, let's continue. So, as I was saying, cholesterol stones. In the cholesterol stones, the basic causes is going to be supersaturation of the bile. In the supersaturation of the bile, you have obesity, high fat intake, and ileal resection. Now, why ileal resection is whatever bile that is excreted into the duodenum, or it has been left into the duodenum, it gets absorbed from the terminal ileum, and that is what we call as enterohepatic circulation. More than 90% of the bile is reabsorbed, only 10 is excreted, and bile consists of bile salts, which is responsible for emulsification of fat. And when you do not have enough amount of bile salts, it is now going to cause accumulation of cholesterol, resulting in cholesterol stones as well. So you have obesity, high fat intake, and ileal resection. Now, apart from this, what else is going to add on to this? Any infections of the gallbladder can also precipitate development of gallstones. Now, stasis of the gallbladder is because of prolonged fasting. It is because of prolonged fasting, secondary to the total parenteral nutrition, pregnancy, usage of drugs like octreotide, and secondary to burns. All these are going to add on to result in development of cholesterol stones, right? Now, just to understand, the first three that you told, it is because of supersaturation of bile. It is because of the supersaturation of bile. Now, infection is a standalone problem. All these which are present, these are going to be because of hypomotile it's a hypomotile gallbladder. So supersaturation of the bile and the hypomotile gallbladder are the concomitants, so the reasons. Now coming to the pigmented stones, now there are two varieties of pigmented stones that you can see in the gallbladder, right? The first variety is what we call it as the black pigmented stones. The other one is what we call it as brown pigmented stones. So we have the black pigmented stones and the brown pigmented stones. Now the black pigmented stones is secondary to a hemolytic disorder. It is secondary to the hemolytic disorder. Your brown pigmented stones are secondary to infection. So here infection is usually because of E. coli and Klebsiella. Now the hemolytic disorders that you can talk about here is going to be sickle cell anemia, hereditary spherocytosis, beta thalassemia, sickle cell anemia, hereditary spherocytosis, beta thalassemia. It can be secondary to the prosthetic heart valves, any of this, right? All these will add on for development of hemolytic disorders, right? In the brown pigmented stones, it is because of E. coli and Klebsiella. What is so special about E. coli and Klebsiella? Because they secrete an enzyme which is called as beta glucuronidase. Now this beta glucuronidase converts the water soluble bile. It converts the water soluble bile, which is called as simply as the conjugated bile, to a non-water soluble, that is going to be your unconjugated bile. It will result in non-water soluble, or I can say it will result in unconjugated bile. Now conjugated bile is going to excrete out of the body, whereas unconjugated bile will recirculate back, and as the concentration of unconjugated bile will increase, it will now result in precipitation of the stones, right? So usually when you talk about what is the composition, so black pigmented stones, the composition of the black pigmented stones is going to be calcium phosphate and calcium bicarbonate. It is calcium phosphate and the calcium bicarbonate. Brown pigmented stones, on the other hand, when you look at the composition of the brown pigmented stones, the composition of the brown pigmented stones is going to be calcium palmitate and calcium stearate. It is the calcium palmitate and the calcium stearate. So this is in the context of the composition with respect to the pigmented stones, right? Now, as we all know, presence of gallstones per se does not result in development of cholecystitis. So we need to understand that what results in development of cholecystitis, right? So we'll talk about cholecystitis, or I can say acute cholecystitis. So when we say an acute cholecystitis, it is defined as acute inflammation of the gallbladder. It is an acute inflammation of gallbladder is what we call it as acute cholecystitis. Is going to be an acute inflammation of the gallbladder. See? Now, you need to understand that when you talk about acute inflammation of the gallbladder, that is acute cholecystitis, it can be lithogenic and non-lithogenic. It can be lithogenic and it can be non-lithogenic. Now, what do you mean by lithogenic and non-lithogenic is where the inflammation of the gallbladder is secondary to stone, we call it as lithogenic cholecystitis, or also called as the calculus cholecystitis. Calculus cholecystitis. Non-lithogenic is without the gallstone, there is an inflammation, right? So in a non-lithogenic, that is absence of gallstones, there is absence of gallstones, but there is inflammation of gallbladder. There is an inflammation of gallbladder. There is absence of gallstones, but there is presence of inflammation of gallbladder, and that is what we call it as the non-lithogenic cholecystitis. Now, the examples of non-lithogenic or the causes that I can tell you about the non-lithogenic cholecystitis, it is usually secondary to hypovolemic shock. It is secondary to hypovolemic shock. It can be secondary to an infection, example like Clostridium. It can be secondary to E. coli. So when the Clostridium and E. coli causes inflammation of gallbladder, it is what we call as emphysematous cholecystitis. This is what we call as emphysematous cholecystitis. It can also be seen secondary to ruptured Rokitansky-Askov sinus. Ruptured Rokitansky-Askov sinus. And this is what we call as xanthogranulomatous cholecystitis. Xantho is yellow in color. It is granulomatous cholecystitis. It is the xanthogranulomatous cholecystitis, right? So, that is the example of non-lithogenic causes of acute cholecystitis. Now, for lithogenic causes, you have a risk factor which is called as a 5F risk factor. And at the first one, the patient must be a female. If she is fat, if she is in her 40s. So, female for fat 40, if she is fertile, and if there is complaints of flatulence. If there is complaints of flatulence, right? This will result in acute cholecystitis. So how does a patient of acute cholecystitis present to you? The clinical features of acute cholecystitis. So the clinical features of acute cholecystitis. Number one, the patient, see there's a triad for acute cholecystitis, right? So try to understand what is the triad. So the triad for the acute cholecystitis is going to be pain, fever, and leukocytosis. It is going to be pain, it is going to be fever, and this is going to be leukocytosis. This is going to be pain, fever, and leukocytosis. Devaji sir, can you tell when are you going to continue BLS section of abdomen, sir? Please reply. But Devajit, we have already started abdomen. We have started with hernia just to get it sensitization. I think hernia will be done in another 2 weeks. 6 more classes for hernia. And after we are done with the hernia, then we will go ahead with, I'll try to complete hernia in 1 week because we've already done the basic of hernia. Next we'll go into the next part of the hernia. Once we're done with the hernia, we'll start with abdomen. Then we'll start with esophagus. Okay? That's a promise. We've already decided to do so, we'll do so. Now when we talk about pain in acute cholecystitis, where does the pain starts from? Right? Now remember, this has a very peculiar pain. This is going to be a radiating pain. The pain in acute cholecystitis is going to be a radiating pain. So where does it radiate to? Now in the radiating pain, remember it will start from the right hypochondrium. So pain will be in the right hypochondrium. It will radiate to epigastric region. It will radiate to the epigastric region. It will radiate, it is going to radiate to the right tip of the shoulder. It also radiates to the right infrascapular region. Right infrascapular region is going to be right infrascapular region. Now why does it radiate to the epigastric region? It is mediated by vagus nerve. Right tip of the shoulder is mediated by the phrenic nerve, and right infrascapular region is radiated by the T7 vertebra or the T7 dermatome, which is going to pass through the same plane. Okay? So that's with respect to pain. So you have pain, fever, leukocytosis. Leukocytosis is elevated WBC count. Leukocytosis is an elevated WBC count. So on examination, there'll be right hypochondriac tenderness. There'll be Murphy sign positive. Now what is this Murphy sign positive? Right? There is mid-inspiratory arrest on deep palpation. There is presence of mid-inspiratory arrest. The mid-inspiratory arrest on deep palpation, on the deep palpation of right hypochondriac region. In the right hypochondriac region, that is what we call as Murphy sign positive, right? So in the right hypochondriac tenderness, there is Murphy's sign positive that you're going to see, right? Now, you would like to evaluate it in terms of investigation. I will get a complete blood count, that is CBC, to be done. I will do a USG of the abdomen. Now, USG of the abdomen will give you presence of gallstone, and there is edematous gallbladder wall. There is an edematous gallbladder wall. So how do you know it is edematous? The wall thickness is more than 3 millimeters. Here the wall thickness is going to be more than 3 millimeters. The wall thickness is going to be more than 3 millimeters, right? Another investigation that you can do is something called as the HIDA scan. HIDA stands for hepatobiliary. It's an hepatobiliary immunodiacetic acid scan. That's a HIDA scan. right? Now, once you're diagnosed, it is an acute cholecystitis. The management for acute cholecystitis. The management for acute cholecystitis. You have to see whether we are managing. The management for acute cholecystitis is seeing whether the patient presents to you within the first 72 hours of onset of pain, or whether the patient is presented after 72 hours of onset of pain. So within the 72 hours of onset of pain or after the 72 hours of onset of pain. If the patient presents within the first 72 hours of onset of pain, then I will take the patient for laparoscopic. We'll take the patient for laparoscopic cholecystectomy. We'll do a laparoscopic cholecystectomy. If patient presents to after 72 hours, then we'll go ahead with conservative management. So in the conservative management, the first thing, we'll keep the patient nil per oral, start the patient on IV fluids, give adequate analgesia, start the patient on IV antibiotics, start the patient on IV antibiotics. Now once the patient responds, ask the patient to go back home and then come after 2 to 3 weeks. So once the patient comes back after 2 to 3 weeks, when a patient presents after 72 hours, ask the patient to come back after 4 to 6 weeks, not 2 to 3 weeks. Ask the patient to come back after 4 to 6 weeks, and here we will go for laparoscopic cholecystectomy. We'll go ahead with laparoscopic cholecystectomy, right? So this is how you will deal with your patients of acute cholecystitis, right? So did we cover that? Yes, we did cover cholecystitis, right? Next, we're going to choledocholithiasis. Now, when you talk about choledocholithiasis, choledocho is bile duct, lithiasis is stone, so it's a CBD stone. So the next topic is going to be choledocholithiasis. So when you look at the choledocholithiasis, it is CBD stones. It is stones in common bile duct. It is stones in common bile duct is what we call it as choledocholithiasis or CBD stones, right? Now when we talk about the choledocholithiasis, let's understand that what are the different varieties that you have. Now in the choledocholithiasis, we have 3 standard varieties of CBD stones. You have the primary CBD stone, the secondary CBD stone, and retained CBD stone. So we have a primary CBD stone, we have a secondary CBD stone, and then you have a retained CBD stone. So primary CBD stones are those stones which are formed in the bile duct. Stones formed in CBD, stones formed in CBD secondary to bile duct obstruction. Secondary to bile duct obstruction. Secondary CBD stones are stones formed in gallbladder. They're formed in gallbladder and dislodged into bile duct, into CBD. Retained CBD stones, stones in CBD within 2 years of cholecystectomy. Within 2 years of cholecystectomy is called as retained CBD stone. Now, any patient of all these, the usual incidence is of secondary CBD stones, right? So the most common variety of the CBD stone that you will see will be a secondary CBD stones, right? Now, just to get the things into perspective, you need to understand that if you take this as the representation of the liver, take this as the representation of the liver. Let's say this is the right hepatic duct, this is the left hepatic duct. This is the right hepatic duct, left hepatic duct, common hepatic, cystic duct. Together, this is the gallbladder, and this is the common bile duct. This is the common bile duct. Now, you need to understand that this is the CBD diameter. This is the cystic duct diameter and the CBD diameter. We'll try to understand. So, look at the diameter of the cystic duct. The diameter of the cystic duct is 3 millimeters. The diameter of the common bile duct is 6 to 7 millimeters, right? So the diameter of the cystic duct is 3 millimeters. The diameter of the CBD is 6 to 7 millimeters. Now imagine if there are multiple stones which are formed. Imagine if there are multiple stones which are formed in the gallbladder, right? Usually the most common site for formation of gallbladder stones is this hunch, which is called as the Hartmann's pouch, the most dependent area of the gallbladder. Now you need to understand that if a stone is going to pass through the CBD or through the cystic duct and get into the CBD, by logic I can say the size of the stone should be less than 3 millimeters. A stone which is less than 3 millimeters, can it block a duct which is 7 millimeters? The answer is no. So usually when you talk about the clinical presentation of the CBD stones, the clinical feature of CBD stones, the clinical feature of the CBD stones can be formed in 3 counts. One, it could be absolutely asymptomatic. We can have an incidental finding. Second, it can only cause obstructive jaundice. It can cause obstructive jaundice. Third, it can result in cholangitis. That is inflammation of the bile duct. So cholangitis is the most severe form, and this is your inflammation. This is the inflammation of CBD. So if a patient develops cholangitis, there is a classical triad which is called as the Charcot triad. Now because the bile duct is blocked, obviously bile will not be able to flow, there will be jaundice. Inflammation of the bile duct will cause pain and fever. So Charcot triad is associated with pain, fever and jaundice. Pain, fever and jaundice, but all 3 of them are intermittent. All 3 of them are intermittent. If the patient does not take any treatment, the patient now land up into sepsis and altered mental status. Sepsis and altered mental status. So if you combine all these 5, that is pain, fever, jaundice with sepsis and altered mental status, it is called as the Raynaud's pentad. So pain, fever, jaundice is a Charcot triad, but altered sensorium and if you add mental status, that is altered mental status and sepsis, it is going to be Raynaud's pentad. It is going to be Raynaud's pentad. So for cholangitis specifically, the investigation that you can do is going to be ultrasound of the bile duct and directly take the patient for MRCP. It is going to be MRCP, right? Now, how would you like to manage? Management of the cholangitis. The first line management, we're talking about cholangitis, is to keep the patient nil per oral, start the patient on IV fluids, give IV analgesia, as well as IV antibiotics. Wait for 48 to 72 hours, and after that, to extract the stone, do an ERCP. ERCP is your endoscopic retrograde cholangiopancreatography. Cholangiopancreatography. Now this ERCP is to extract the stone. So ERCP with CBD stenting has to be done. If it fails, then lap exploration. That is laparoscopic CBD exploration with T-tube placement. If laparoscopic fails, then open CBD exploration. Open CBD exploration. So these are the steps you need to know if the primary plan fails, right? So this is how you're going to manage your patients of cholangitis. Okay? So I think we have covered the last topic also, and the last topic we had was Choledocholithiasis. Okay? Courvoisier's law is just a small thing. What is a Courvoisier's law? A palpable distended gallbladder is seldom secondary to stone. It cannot be because of stone. Remember, a stone cannot cause a gallbladder to be distended because stones are usually associated with chronic cholecystitis, and any chronic inflammation of the gallbladder will be associated with fibrosis, and a fibrotic gallbladder cannot expand. So hence, it is not correct. So Courvoisier's law, in general, if I write it here, a palpable distended gallbladder is usually not because of gallstones. Not because of gallstones. Reason is gallstones are associated with chronic cholecystitis. Gallstones are associated with chronic cholecystitis. And chronic cholecystitis, that's a CC, chronic cholecystitis, it is associated with fibrosis. So any chronic inflammation healed by fibrosis. A fibrotic gallbladder cannot expand. So Courvoisier's law basically tells you if it's a dilated, distended, or palpable gallbladder, it is anything else than stone. Then you have to think in the context of periampullary carcinoma, distal CBD malignancies. There's one exception to the rule when you have a CBD stone, a sudden impacted CBD stone or a double CBD stones are present, that can result in your Courvoisier's law. One more exception to the Courvoisier's law is going to be mucocele of the gallbladder. So two exceptions that you have to remember for the Courvoisier's law. One is the mucocele of gallbladder, and if you're double impacted stone. A double impacted CBD stone. These are the two exceptions to the rule in. Right, so this is the exception of rule for your Courvoisier's law. Okay, so this is all that you should know in the hepatobiliary system. Okay. So for any questions, any doubts, quick feedback. So these were your previous exam questions. We have already covered it. So kya pucha tha? I have, okay. So they've asked you to write a short note on hydrated cyst, pyogenic liver abscess. We have done so. They asked you to tell you about child criteria. We did that. They asked you the difference between amoebic and pyogenic liver abscess. This is for 10 marks question. We have done that. Write about cholecystitis and management. We have done that. Choledocholithiasis, investigation, management. We have done that. What is Courvoisier's law and what are his exceptions? We have already spoken about. So these were your previous exam questions from hepatobiliaries and we have completed. Okay? Chalo. If you have any questions, feel free to ask. Otherwise, thank you so much for joining today. Any other questions? Quick feedback. All right, so thank you so much for joining. See you guys in the next session of Farre. Until then, enjoy. If you have any doubts, specifically in few topics where you want to read a little bit more, we also have a BLS series that is called as the Bile and Love Learn with Dr. Sandeep, where we have discussed in general, in detail about all the topics. It is there on YouTube. It is free. It is on our PW MedEd channel only. It is called as BLS. If you want any questions, anything that you want to read from breast, thyroid, trauma, we have already completed the entire series on that. We are doing hernia right now. Want to watch it? Please do come and watch it there as well. Thank you so much for joining. Until then, bye. Take care.